Thank you for joining us for today's webinar, Understanding Managing Nitrous Oxide Leaks. My name is Kaz Winarski and I'm an anaesthetist in Geelong, Victoria. I'm chairing this meeting tonight that has been organised by ANZCA's Environmental Sustainability Network. I recognise that I'm hosting this webinar from the country of the Wadawurrung people of the Kulin Nation. I would like to acknowledge and pay respects to the traditional custodians of country throughout Australia and to Ngā Iwi Māori as the tangata whanau of Aotearoa and the special relationships with the Pacific people. I'm unsure of where attendees are in their effort to manage nitrous oxide in their healthcare facilities, and I'm hoping that tonight will give you all the tools to go and start the conversation in your place of practice. To give a rough lay of the land, the overall concept is that clinical administration of nitrous oxide is decreasing, and it has been identified that hospitals often purchase far more nitrous oxide than they require. The last 5 years of research has asked the question, where has it gone, and why does decreasing clinical use not translate to decreased nitrous oxide purchasing? Whilst clinicians and facilities management have been working on solutions to the problem, as a snippet of the degree of the problem, this data from my place of work demonstrates that the average leak fraction, or the percentage of purchased nitrous oxide that is not administered to patients, fluctuates from 41 to 61% over a 10-year period. Next slide, please. And in a single year, nitrous oxide represents 7% of our Scope 1 emissions, those that my healthcare services is directly responsible for. There are many case reports of similar situations across Australia, New Zealand, the NHS and America. It is not acceptable that a large portion of these emissions contribute nothing to patient care or operating services. Next slide, please. Those of you who know me will know that I can't resist an opportunity to throw in an adventure sport analogy. Tonight's analogy is the steep, powdery boot pack. The first steps of these are the hardest, and the people who forge them have to put in a lot of effort for seemingly little forward movement. The benefit is that those who come after them have an easier, safer path to tread. Tonight, we will hear from leaders in this field who have trudged the boot pack. Leaders from the international and local community who are banding together to demonstrate that effort can make substantial impact in the fight for climate health. We will be holding discussion at the end of the fourth speaker. Please submit questions in the chat as they come to you. We have a moderator tonight, Dr. Beth Hall in Christchurch, who will identify the questions that will generate the most discussion. I would like to take this moment to acknowledge the work of clinicians and researchers in this field who have been working tirelessly, with a particular nod to Chris Mitchell in WA, and the support of the ANZCA ESN staff who have made the logistics of tonight happen. The first speaker tonight is Dr. Paul Southall from the NHS. In addition to his current role with the Royal College of Anaesthetists, Paul was elected to council at the end of 2023 with sustainability as his main focus. His principal interests within sustainability are coordinating the national and international collaborative projects on reducing the environmental impact of anaesthetic practice, the impact of pharmaceuticals on water and environmental health, and integrating human factors and ergonomics into sustainability. Take it away, Paul.
Thanks, Kaz, and nice to virtually meet you all. Thank you for having me. So I'm just going to share my screen and I'll get going. Here we go. So in essence, what I'm going to deal with is the elephant in the anaesthetic room, if you pardon the pun. A bit about me, as Kaz has already kind of mentioned, I'm an anaesthetic consultant up in the UK, and I'm a Royal College environmental advisor and a member of the College Council. So I'm not going to spend a huge amount of time on this particular topic because I would imagine most people already know a decent amount about why nitrous is an issue. But in essence, the reason we're interested in it is a very potent driver of climate change. It has a CO2 equivalence of nearly 300. It's also a centennial gas, so it sticks around in the atmosphere for well over 100 years, so that any impact that we have on it now will have lasting impacts in the future. And something that isn't mentioned very often but is equally relevant is that it is a drug of abuse. And one large 10,000 litre cylinder in a manifold is worth quite a lot in the long run hands. There have been quite a few instances in the UK, these big cylinders being stolen. Why is healthcare interested specifically in anaesthetics, even more specifically? Well, as we all know, nitrous has been ubiquitous in anaesthetic practice for well over a century now. This stunned me a little bit when I first read it, but there's been some estimates on the contribution of nitrous oxide, medical nitrous oxide, to overall climate impacts going back to the mid or early 90s. And the estimates, they're anything from 0.1% to 1%. I've seen some estimates of 2% of the entire global footprint. Now, those higher estimates are probably a little bit of an overestimate. But even if we take 0.1% as a contribution for a drug that is dwindling in use, the entire aviation industry is only 40 times higher than that. And it kind of puts it into perspective about what we can do to change things. We're interested also because it's traditionally supplied via a manifold of cylinders, pipelines to ensure a continuous supply. It's deemed as an essential gas. There are documents in the UK called hospital technical manifolds, and there'll no doubt be similar ones in Australasia. And when something is deemed as essential, so nitrous being an essential gas, puts it in the same footing as things like the water supply and the electricity supply. It has to be maintained as a continuous supply. And the issue, which I'm sure you're all aware of, is that these manifolds are very leaking. So most trusts, a decent number of trusts in the UK have done an audit now of the leak. The national average is coming out at around about 94%. My own organisation was 99.2, believe it or not. How does that equate in real terms? Well, last month, we procured 10 million litres of manifold nitrous oxide in the UK, which is the equivalent to about 4,400 tonnes of CO2. And to put that in a graphical perspective, this is what it looks like. You'll see a bit of a drop off in early 2020. Can't quite think what might have caused that. But in essence, that was kind of the start of a trend of things that went downhill from there on in terms of its usage. So this is just a decrease in procurement that reflects a decrease in anaesthetic usage. So why now? Why do we want to change things now? Well, whenever I get asked that question for anything sustainable, the first response is, well, why not now? Why can't we do it now? The use of nitrous is declining anyway in the United Kingdom, so the timing was good to try and look at how we could decrease that and how we could help with changing the way that nitrous is used in the UK. And there is an alternative. So this is a photo from one of the hospitals in my trust. This is a size E cylinder that plugs in directly to the back of the anaesthetic machine. So in essence, this is one of the trodded ones that we can move between theatres. But in theatres where we have a perceived high usage of nitrous oxide or higher than average usage of nitrous oxide, we have them bracketed to the wall. And they, in essence, have a regulator on the top with a pressure gauge and a Schrader valve so that they can connect directly into the anaesthetic machine, much like the pipeline supply would. What's really happened in the UK?
I don't mean to interrupt, but we're just getting a couple of requests that the screen share isn't quite coming through.
Okay.
I'm just wondering if you can change either the presenter mode.
Hold on. Is that any better?
I'll just get confirmation.
Yeah, Paul, that's better now.
Yeah, that's better.
Okay.
Right.
Lovely.
Cool. Sorry about that, Paul.
Hopefully,
No
worries. Hopefully, you haven't missed too much. So, what have we already done in the UK? Well, the fact that this is a draft of the first document of this shows how long I've been involved in it. But in essence, this was a document that was produced by NHS England a while back now that was estates and facilities focused to look at quantifying leaks and how we go about reducing those leaks. The latest version of that guidance is due to come out fairly soon, which I'll touch on in a second. So we've already done stuff that's been focused very much on estates and facilities in the UK, but there was a big gap in terms of clinical involvement on what we could do with reducing the use of manifolds in the UK. And that was the gap that we tried to bridge, which I'll talk about going forward. So what did we do? Well, what we thought and what I'd thought right from when I started work with the Royal College was that there was a big gap, as I've mentioned in clinical statement, on why we no longer need these the manifolds to supply nitrous. And in essence, beginning of this year, so spring in the UK, April 2024, I had a by chance meeting with a member of the team from NHS England who were updating the toolkit. And I said, well, it would be nice to get something clinical in this. This is something we're looking at doing at the Royal College. They said, well, the toolkit is due to come out at the end of this year. Initially, the end of the summer was the estimate. Would it be possible to get something done by July? Those of you who have any dealings with Royal Colleges and colleges, this isn't a criticism, but they worked slowly. So that was deemed to be a bit of a big ask, but we thought we'd give it a go. So I made a decision that I was going to write what was initially going to be a position statement for the Royal College on getting rid of nitrous manifolds. I had a chat with my other fellow environmental advisors who were obviously very on board with it. So we did the first draft end of April. We then had discussions with the Association of Anaesthetists, which is kind of like our anaesthetic union, for want of a better term of it, in the UK and Ireland, and with the College of Anaesthetists of Ireland, on whether there'd be any interest in upgrading it to a consensus statement rather than just a position statement. That was in early May. Unsurprisingly, they were very keen on this. We then also thought, well, actually, what we get approached with as clinicians and people who want to drive change sustainably is that the argument that we always get back is, well, what about, when it comes to nitrous, what about paediatrics? What about obstetrics? So we thought quite early on it was very important that we got the specialist organisations, so the Association of Paediatric Anaesthetists of Great Britain and Ireland and the Association of Obstetric Anaesthetists to have some input in this statement. We spoke to them, and again, unsurprisingly, they were very keen on coming on board. We also had a chat with BOC, the British Oxygen Company, who supply the vast majority of the nitrous in the UK and in a lot of the developed world, should I say, sorry, just to give them a heads up of what we were thinking of doing. So that was kind of the end of May, beginning of June. That was all going quite well. It was then, thankfully, approved by the Royal College Council early July 2024, and then the statement was released at the end of July. And there's two reasons why I've laboured this slide a little bit. One is that if there's a will to do stuff, we can do stuff quickly if we need to, and we can produce good documentation and good guidance quickly if we need to. And I think that gets underlooked quite a lot because traditionally these things take quite a long time to do. But when we know it's right, and when we know there's a body of people who know it's right, we can get it done quick. And this is in essence what we produced. So page and a half, a little bit of background at the top for people who might not be particularly familiar with what we're trying to do for nitrous. But the main consensus recommendation was that we recommended that nitrous oxide should no longer be considered an essential drug in modern anaesthetic practice, and that continuous supply is no longer essential. That word essential was picked specifically because it ties into those hospital technical manifolds. So if we say it isn't essential, then effectively that guidance can be changed, and that guidance is in the process of being changed now. We tried to be very unambiguous and say this is about pure nitrous oxide only and doesn't refer to Entonox. And by and large, that then led on to an editorial in Anaesthesia, which came out at the beginning of this month, which I co-wrote with Cliff Shelton, who some of you will know, who's very big in sustainability in the UK, and Alethea Shakira, who founded the entire nitrous oxide project in the UK. And the aim of this document was very much the why and the how, but also how to go about dealing with any pitfalls and how you go about doing this, and the process of how you would think about getting rid of these manifolds and what the difficulties might be and the problems that you might face. So the overall aim, we know why we did it, but what was the aim? Well, the unofficial aim is that if you've got a 94% leak and you want to get rid of the manifolds, then you should aim for a decent reduction in nitrous oxide associated emissions. So we haven't formally documented this, but I think we can realistically get a 75 to 90% reduction if we get rid of the manifolds. The consensus statement has specified that we want this done by the end of 2026-27. So it's soon enough that we're not hanging about, but also enough time for people to get it done, to procure the stuff that needs to be procured. And the secondary aim, which we've got in principle, but we haven't got formalised yet, is a commitment from the medical gas suppliers that they will refill return cylinders rather than cracking them open to air. And that, in essence, will complete the circle. We've got rid of the manifolds. We've changed the way that we're using nitrous oxide, and then the cylinders that are sent back to them will be refilled rather than cracked. And that should complete the circle, hopefully. A little bit on what comes next, just very briefly. So far, pleasingly, we've had no resistance in the UK to this. We've had no pushback for it, which is unsurprising, but still nice. Spread the word internationally. Hence I'm here, partly, as well as other places around the world. At the end of September, the beginning of October, we're going to meet with some of the big machine manufacturers, and the aim is that we're going to do a very brief, simple, straightforward how-to guide, because each machine has different alarms, different processes for using nitrous, so we want to make sure that we're dealing with all of that. And that should come hopefully by the end of the year, and then to start to look at alternative solutions for Entonox. those of you with an interest will know that it's the even bigger elephant in the anaesthetic, well, in the delivery room. And in essence, the golden rule of sustainability that I always use is that if we make any change, it's got to make the clinical practice that comes following the change at least as good, if not better, than what's come before, as well as the sustainability changes. We're not quite there with Entonox, but we will get there. This is the first step. We do nitrous, and then we look at what we can do with that secondly. And that's me done. So thank you very much for listening, and my apologies for the issues to starting off with. Hopefully it didn't disrupt it too much. And as we said at the beginning, I'll take any questions at the end if needed. But thanks so much.
Fantastic, Paul. Thanks for that. That looks like some really impressive work that you've completed, and in a relatively rapid time frame. Our next speaker is Dr. Strotbeck, who has worked as an anaesthetist in Dunedin and was previously the Chief of Anesthesiology at Virginia Mason Medical Center in Seattle. He has been instrumental in identifying the scope of nitrous oxide leaks and implementing the change to point-of-care nitrous delivery across a 10-hospital system in the US Pacific Northwest, and was a key member of the Cascadia Collaborative, which created a playbook and hosted 2 webinars on nitrous oxide waste. Dr. Strotbeck.
Thank you so much for allowing me to join this meeting, and I am very much enjoying learning so much about the variety of approaches, and I'm very inspired by our last speaker to push forward on the American Society as well. It's my pleasure to share a little bit about the hospital I most recently served out in the US, the Virginia Mason Medical Center, where we have an academic medical center and function as a quaternary referral center for about 5 states in the Pacific Northwest. Relatively small hospital as it pertains to overall numbers of beds, only about 250 staff beds currently in use, but we do conduct about 26,000 general anesthetics per year. We do have a small labor and delivery ward that delivers roughly 500 babies a year, but quite a lot of procedural space and a couple of freestanding surgery centers as well. Virginia Mason is part of a large national health network in the US of about 150 or so hospitals called Common Spirit Health. And the CEO of Common Spirit Health, shortly after Virginia Mason joined the system, announced a massive climate action plan that would call for eventually a net zero by 2050 for all energy and emissions, but a near-term goal in 2030 of reducing our Scope 1 emissions by 50%. This is a big lift in an area in which natural gas continues to be a very substantial contributor to our emissions. And so looking for other more affordable and achievable changes was definitely high on the list of our sustainability team. I partnered with a climate and sustainability director named John Lee, who attended the Clean Med conference in 2022 in Utah and came back very inspired by the work of Brian Cheeseborough, who had identified substantial waste of nitrous oxide in the Providence Health System on the west coast of the US. And he said, why don't we take a quick survey of what's going on with our system here at Virginia Mason? And we were very surprised to see that even though we've been patting ourselves on the back since 2019 about eliminating desflurane from our system, we still had a very, very large overall footprint as far as our metric tons of CO2 emissions related to anesthesia. And the biggest contributor of this was truly our nitrous purchases each year. We were fortunate to have electronic anesthesia records with very granular data available. And as we dove into it, we found that we were using around 31,000 liters of nitrous per year. However, we were purchasing nearly 1.6 million liters of nitrous oxide just for this one hospital. And this resulted in an overall waste of about 98%. This clearly was consistent with what others have published. We were shocked and dismayed that we were wasting this much nitrous each and every year and creating substantial environmental harm with no real benefit to our patients. A big function of our system was the fact that we used cryogenic nitrous as our source for our manifold, and this by itself is going to be very difficult to get any kind of leakage control under. Brian Cheeseborough had mentioned that he had gone through this evolution as well and gone to regular compressed gas cylinders, and still was only able to get down to about 70% efficient. So we decided to take the big step forward and initially carry out some education to our providers about their fresh gas flows, giving them reports about their overall usage, seeing if we could change a little bit more about the consumption of gases, but we knew that we would eventually need to make the migration to point of care use. And so in September of 2023, we decommissioned our central supply and went to point of care. And in the period of time since that decommissioning, our usage has declined significantly. We have dropped down to approximately 380 liters per month of nitrous oxide, roughly 34 cases per month utilize it. And this really results in a very, very small amount of overall nitrous needing to be acquired by the system. In the Pacific Northwest, we have a number of additional hospitals that partner with us in our health system. We have kind of a regional network of 10 hospitals, and John and I work together to recruit a clinical leader at each of these facilities to become a champion around the topic of decommissioning. We then would meet with our facility directors, environmental leaders, and peri-op leaders and biomedical engineering, and go over the stepwise process necessary to create a changeover to point of care. Eventually, this would typically take about 6 to 8 weeks worth of meetings on and off over Zoom, and getting everyone to the table at times was challenging, but we would then send a letter to the chief clinical officer and the administrative leader of the hospital, notifying them of the changeover date, and carried that out. Typically with our local bioengineering teams, although 3 of the 10 hospitals did choose to rely on using their MetGas certifiers who provided the ongoing compliance of their system, interestingly, which had been quite leaky, but they were able to do this at a fairly low cost. This next chart shows some historic purchasing data, and it's not that exciting to show, except that for 2023, we saw a substantial decline, Virginia Mason being in the middle of my slide, being the situation where we had a decline in nearly 1,000 kilos of nitrous between the 2 years. We expect that number will drop again precipitously, because again, that really accounted for only the last 4 months of calendar year 2023. Our other hospitals together combined for a significant reduction. Some of this was education, but at the beginning of 2024, the rest of the hospitals here listed in green decommissioned over a period of a couple of months, and then Mercy Medical Center decommissioned in June of 2024. St. Anthony in Oregon will decommission as their centrally supplied system runs out. They have indicated their MedGas supplier they'll no longer purchase the large format cylinders, and they will go to point of care at that point in time. We expect that by 2025, you'll see this dramatic reduction in our overall greenhouse gas emissions, with nitrous again becoming a very small part of our overall emissions for our medical centers. And we are hoping to take this. I was in meetings with sustainability directors this morning from the larger 150 hospital parent system, and we're looking to roll this out over the coming 12 months across the rest of the nation. Because again, we have only one planet. So thank you very much.
Fantastic, Wynne. That sounds like a really collaborative effort to create some significant change. And that looks like it's going to spread through to a few other sites as it rolls out.
Yes, that's right.
Fantastic. Our next speaker tonight is Miss Kelly Williams, and Kelly is an environmental sustainability and climate change manager. Her qualifications include Bachelor of Environmental Science, Graduate Diploma of Environmental Health, and Master of Disaster Resilience and Sustainable Development. Kelly is responsible for the implementation and ongoing development of the Green Metro North Sustainability Strategy 2021 to 2026, and the evolving responsibilities and commitments of the health service into the future with regards to environmental sustainability, climate resilience, and emissions reduction across all aspects of clinical and non-clinical infrastructure and service delivery. Kelly. We're really excited to hear your work up in Queensland.
Thank you very much. I'll just share my screen. Please let me know if you can see that whole slide. Is that good and clear?
That looks good.
Perfect. Okay. Thank you very much for having me. It's slightly intimidating being in a panel full of doctors, because I'm obviously coming from the sustainability officer side, but it's also awesome because we all need to work together on this important mission. So I'm very grateful to be included. I'd first like to acknowledge the traditional owners on the lands from which we're all meeting. And for me, this is a very great opportunity to include traditional knowledge, apply sustainability as a caring for country, and contribute to equity and health and ecosystem services. I just wanted to show you that's our one-page snapshot of our strategy. So you'll notice here that there isn't a group of called medicines and gases, but the way we kind of approach this is that we have green facilities, which is everything that goes on in our facilities. We have green monitoring, which is our data and data monitoring, reporting, target setting, that sort of thing. And then under our green initiatives, where we have waste and energy, that sort of speaks to that side of it. So this is our strategy that we're 3/5 of the way through and progressing well. So I just wanted to start by saying under that green facilities pillar of our strategy, I'm developing a nitrous oxide reduction plan for our health service. It's probably worth noting that we are the largest health service in Australia in terms of population and staff and geographical spread, and so therefore also the largest one in Queensland, and quite often the work that we do informs some of the priorities and directions of the other health services in Queensland. So we take that very seriously about leading in this space. So before I came on board in my role a year and a half ago, there was a very passionate champion, Dr. Mary O'Shea, anaesthetist at the Prince Charles Hospital. I'll talk a little about that in a moment, but we did our first pilot case of nitrous oxide at the Prince Charles. But what we're going to do in this full health service plan is take a bespoke approach to each of the other facilities, because they are all actually quite different in our health service, and they're at various, they have different clinical services that they offer, but they're also at different ages and stages of new development. So we've got some capital expansion projects where we're building new buildings and that sort of thing. So we can't really apply a one-size-fits-all approach. We are putting input into the design of the new buildings. You may not be aware, but there's a bit of a trend in healthcare facility design that when you're designing a new building, you literally take the plans from the old one and just kind of, without giving it a lot of thought, implement everything that was already in the old building and keep going from there. I think that's silly. I think that every new building design is an opportunity to take stock and review and say, what do we really need? What do we need to get rid of? What do we need to change? And our position with nitrous oxide on this is that we're aiming to eliminate reticulated nitrous oxide from all new builds. And I suppose with the one compromise that we may include a small reticulated system only to birthing suite and focus on the use of portable cylinders in other clinical areas. And because of that, we're developing an operational protocol for safe storage and use of portable cylinders, and that includes also the occupational health and safety elements because of the manual handling. We're also looking into the occupational exposure of expired nitrous oxide in birthing suites due to the length of hours that midwives do spend in there with patients who are using the gas, and looking at the crack units to reduce that exposure for the midwives, and also planning to approach the gas supply companies around their protocols at their facilities where they vent the residual gas out of the canisters when they're refilling them. So these are all the things that we are including in our plan. If you look at nitrous oxide use broadly, I would put it into two categories. There is the clinical reduction in use, and then there's the infrastructure governance. So me as a sustainability officer, I can't go around and tell anaesthetists what to do. And I find that there's even a bit of variance there in their commitment to reducing nitrous oxide. Some seem really attached to it. Some seem to be more proactive around reducing it. We do need to work in partnership, because obviously for infrastructure teams and sustainability teams to set about decommissioning or eliminating the reticulated system, you do need to have your clinical staff on board with that. So there's quite a lot of consultation that takes place with the building maintenance engineers, with the executives, corporate services, clinical governance, infrastructure governance, as well as clinical leads and stakeholder engagement. So I suppose I'm not putting in the plan around clinical decision change. I think that I can't put that in my plan, but what I can do is try to work really closely with anaesthetists on this journey. So just some little bit of information about the Prince Charles Hospital. It is the largest cardiothoracic hospital in Australia, 3,200 staff, 700 beds, over 420,000 patients per year. Just wanted to give this as an example, because I think in some cases there can be more willingness to decommission nitrous oxide in a smaller, less acute facility, but we've shown that we can do it in a large facility. So, and then the other part of this is that we currently have a capital expansion project at Prince Charles, and we have confirmed that we will not be including the reticulated nitrous in the new build. This massive expansion project is just going to make the hospital bigger and better, with a much more expanded paediatric service. So yeah, it's pretty exciting that we've gotten that over the line, not to put the nitrous reticulation in. So just to talk a little around what was existing there. So as I mentioned, Dr. Mary O'Shea had been an absolute trailblazer, really working for this cause for about 18 months or 2 years before I came into my role. And you know, there was a strong commitment from the anaesthetists at this hospital. They even decided to stop using it and disconnected themselves from the wall system. But they just couldn't get it across the line. They didn't really understand the infrastructure governance side and the processes that we need to go through to make these kind of infrastructure changes. So once I started in my role, Mary contacted me and I just sort of grabbed it by the reins and went. That's a picture of the manifold that we have outside at Prince Charles. And I might just point to the point at this moment that we do have, you know, very robust servicing and maintenance checks on all of our infrastructure, including nitrous oxide. And I think where some of the reluctance to decommission came from was that, you know, we were getting these reports saying it's been pressure tested, there's no leaks, it's fine, it's fine, it's fine. But what we did find when the anaesthetists completely stopped using the reticulated system and disconnected from it was that the evidence that the service schedule was still in place and the gas bottles kept getting filled. And because we know that none of that went to patients, we do know that it was leaking. And so for that reason, we're not really focusing on leak detection. We sort of think there's enough evidence already in the world that the valves leak, and the bigger the pipeline system, the more valves, the more leakage. So we're kind of not going to spend our time and money on that. We're just focusing more on being proactive around getting rid of reticulation and reducing use overall, but enabling portable cylinders where necessary. And so I took this concept to the Executive Director of Clinical Governance, the Infrastructure Steering Committee meetings where our CEO, COO, CFO, everyone sits on that committee, and just made a compelling case and got their support, and that's how I was able to drive it forward. So like many other facilities, we didn't have a lot of data, but Mary and I tried to pull some data together. And what we could determine from this, the recent data over the last few years at the Prince Charles Hospital was the cost of decommissioning this reticulated system was $23,000. Obviously, that cost would vary depending on the size of your system, but we worked out there'd be an annual saving of $10,000 straight away. And that was based on the figures where there was very little use of the gas happening at the hospital. So potentially the savings will be even more for that hospital. I should have probably mentioned they don't have maternity, which was also what made it much easier to get this over the line at the facility. Now, these photos are completely embarrassing. I'm ashamed to admit that that is how our portable cylinders were actually being stored. The photo on the right is how they were stored, and the photo on the left is just to show that they were kind of stuffed behind those other pieces of equipment and quite hard to access. But that's not really a good example of how portable cylinders should be stored and looked after. So definitely sort of points to the need to have a protocol that really sets out good governance to prevent misuse and theft, and to make sure that if you're relying on portable cylinders rather than a reticulated system, that you've got a service schedule, refill schedule set up to ensure that you don't run out when you do need it. So that's all part of good governance. Now, this is an extremely boring slide, but I'm just showing you this was how we staged the decommissioning. This is just for the benefit of anyone that's going to embark on it. So originally we were trying to aim to do it in November, December last year. But when we kind of went down the risk assessment process and worked with BOC around how to approach this, it was decided that the best time to do it would be when it posed least impact to theatre business continuity. So we chose to do it in the period between Christmas Day and New Year, when typically most people are away. There's less theatre bookings. It's just a lower use time. So there was communications that went out. There was preparation in place, and the work was done between 2 and 7 a.m. in the morning. Also, when the theatres are less likely to be used, and all the alarms, everything were turned off. It went off without a hitch. It didn't interrupt anybody's care. It was really easy when it came to doing it. And these are just some pictures of what it looked like. So the actual pipes and valves are still there. It's just that it's decommissioned, as in all the bottles are gone. There is no gas in the system. And then every outlet in the hospital was labelled quite clearly, as you can see in these photos, just so that there's no misunderstanding from any new staff that come along, that there's no point trying to plug into it. Again, another really boring slide, but this is just to show you that this is the report we got from BOC after the decommissioning that lists all of the like the building numbers, room numbers, barcodes on the outlets and the canisters. This is like their verification to say that the job has been completed properly and fully. And that's it. Thank you. Sort of speed talking there because of our time constraints, but yeah, I hope that was of value.
Fantastic, Kelly. That's really informative, and I'm actually happy to say that this is the first webinar I've ever been a part of that is running ahead of schedule. So we're all doing really well. I would also like to remind everyone who's attending to please put your comments in the chat, because it looks like there'll be about 30 minutes for discussion at the end, and hopefully that can answer the majority of questions that we have. Our next speaker is none other than Eugenie Kayak, who is the Enterprise Professor in Sustainable Healthcare at the Melbourne Medical School, Consultant Anaesthetist and Deputy Chair of ANZCA's Environmental Sustainability Network. Eugenie has worked with Doctors for the Environment and the AMA, or Australian Medical Association, government and medical profession for over a decade to raise awareness of, influence policy, and address the health impacts of climate change and environmental degradation, including healthcare's own impact. She was a member of the Chief Medical Officer Advisory Group for Australia's National Health and Climate Strategy, and is Deputy Director of the University of Melbourne Climate Catch Collaborative Action for Transformative Change in Health and Healthcare Lab. That's quite a mouthful. Eugenie, you are speaking on the nitrous leak management guideline, and I believe you've got some exciting news for us all.
Yes, great. Thank you very much, Kaz and everyone else. I presume you can see my slides. I can't see any of you, but is that all good for the screen?
Looks good. Okay,
well, good evening, and it's an absolute pleasure to be here and to come after such fascinating and informative speakers. It's so encouraging to hear what Kelly has to say about Prince Charles in Brisbane, how they're not really focusing on finding evidence for nitrous leaks, but going straight to decommissioning, which is also obviously what is happening increasingly in Great Britain and Ireland. I think it's fair to say that in Australia, we've been a little bit behind on that, and really in appreciating the scale and therefore the need to act on our infrastructure leaks. So with that in mind, it's actually been an absolute great honour over the last 16 months to lead a collaboration or a consortium of really esteemed anaesthetists in this area and academics, along with the Department of Health and Aged Care, to develop a guideline, a practical guideline for detecting and reducing nitrous oxide leaks in healthcare facilities. And you'll see there that I know there are some on the webinar tonight and others who have really been leaders in Australia in this area, such as Chris Mitchell and Forbes again, and Justin Skono, who have helped develop these guidelines, which became public literally 48 hours ago. So I'm just going to spend a few moments going through them just very briefly, 6 slides to point out some of the key, I guess, messages and ideas from this 25-page document, which you'll be able to find on the government website. So it presents several methods currently used in Australia to detect and reduce leaks for nitrous oxide, including also case studies, resources, and recommended next steps to assist with the detection and reduction of the leak, hoping that identification for us of nitrous leaks will support our healthcare facilities to avoid wastage of nitrous, reduce costs from wasteful nitrous leak, and also prevent environmental harm, because I think many of us are grappling with actually convincing, unfortunately, our healthcare facilities and organisations that this is a significant problem and we need to act. It is a guide and it's intended to assist clinicians and facility managers to identify what might be for them in their hospital the most appropriate method to test for nitrous leaks, and to be able to make an informed choice about the most appropriate way to supply nitrous to a facility, whether that might be minimising their nitrous infrastructure, cylinders, or continuing with nitrous supply, but with a much more rigorous testing and leaking regime. Also, to consider how we can reduce or remove nitrous supply when it's not clinically necessary, and reduce waste from leaks, including through regular monitoring of nitrous supply. I want to make particular note that whilst this collaboration was led by the University of Melbourne in collaboration with the Department of Health, that really, as we've heard tonight, it was coming off fabulous work that's been done and led by others, particularly in the Great Britain and Ireland, Alifa Shakira with the nitrous oxide project, which has been mentioned, the Association of Anaesthetists and Centre for Sustainable Healthcare, where they really identified several years ago the significant greenhouse gas impact from their leaks. For instance, there's 16 sites in Scotland. The leakage of nitrous was equivalent, I believe, to per year to 600 million kilometres of driving a car. And other, healthcare facilities and jurisdictions in Australia that have been leading in this way, in this area. The Green Theatres Network in Western Australia, led by Chris Mitchell. At Western Health, they've been doing some groundbreaking work led by Forbes again. Steve Gaff at the Alfred has come up with a novel way of measuring and detecting nitrous leaks, and Ying Gu at the Women's is also looking at how we can actually address this in our maternity hospitals, and Justin Skono at the Sydney Children's Hospital Network, I think all deserve being mentioned, and I'm sorry for those who I have left off the list. So you may or may not be aware that in December last year, Australia's first National Health and Climate Strategy was launched. It has 49 actions. One of the actions is about reducing emissions from nitrous oxide. And in that document, it states that the Australian government will work with several of our colleges, the ASA and the Australian Nursing and Midwifery Federation, states and territories and industries and suppliers of nitrous to protect healthcare staff and reduce greenhouse gas emissions from nitrous oxide gas by reducing wastage from leaks and from venting, and by educating on appropriate use of nitrous oxide. So why do we need the practical guide? Well, I've touched on that a little bit, but just to re-emphasize what's part of what's already been said, nitrous infrastructure leaks are a significant contributor to emission footprints from our anaesthetic gases. Leaks can be really large when it comes to the amount of purchased nitrous, often over 70%, sometimes as much as 90% of the purchased nitrous doesn't make it to the patient, but leaks prior. And part of this is because nitrous, not only is it relatively cheap, or I think that's one of the actual problems with it, it is relatively cheap, but it's also colourless and odourless. Therefore, we really need to be actively looking for our leaks to detect them. There are numerous, in Australia at least, current and emerging practices to detect and reduce leaks, quite different practices that are being tested and refined across the country, and this guide aims to outline them and give some guidance of which one may work for your facility. In Australia, we have Australian standards that look at our infrastructure. And interestingly, when it comes to nitrous infrastructure, certification, quite rigorous certification is required, but it's only required on commissioning of the nitrous pipelines if there are major modifications or prolonged periods of downtime. The maintenance standards required under the Australian guidelines are probably what we could call quite weak. It often relies on visual testing for integrity of pipes and infrastructure, pressure gauge tests in different areas, maybe within our theatres, and even soapy water bubble test to see whether we may or may not have leaks. So I think it's fair to say, and we know that several healthcare facilities have been found to have quite significant leaks even after passing their regular maintenance tests. So the document provides an overview of methods to detect and reduce nitrous leaks. It describes 4 primary methods, and I'll just run through them very briefly, and there's a lot more detail in the guideline. The first one is the discrepancy method, which describes how you can calculate the discrepancy between the volume of the nitrous that the healthcare facility is purchasing and the volume that's clinically administered. So giving you a guideline of how you might work out the difference between purchased nitrous and clinically administered, and therefore also estimating what your leak amounts or percentages might be. The cylinder weighing method was the method developed at the Alfred led by Steve Gaff, which puts your nitrous cylinders in your manifold on a set of scales, and ideally is done in a period of no use, and by measuring or recording the actual change in weight on the cylinder, it can then be transferred to working out the volume depletion of your nitrous cylinder over a certain degree of time. The pressure testing method is also described, which measures whether there is a decrease in nitrous supply pressure over a period of no clinical administration, and that can be done for your whole healthcare facility or then also for different parts of the healthcare facility if you can use isolation valves. And finally, there's a flow monitoring method, which measures the flow rate of nitrous gas over a certain period. It can do that again for your whole facility, or also as being used in some maternity hospitals, it can be done closer to the point of care as a measurement of how much nitrous is actually being administered. We've tried to provide a decision pathway, a very simplified decision pathway to just assist in choice of method. And by no means is it descriptive. It's to give those who are wishing to look for nitrous leaks an idea of what may be the best method for their facility, whether nitrous can be interrupted or not. It might depend whether it's a maternity pediatric hospital or not. The desire to work out where the actual leak may be, and also it's very much dependent on what equipment may be, it may be accessible to you or not. So the guide also has some recommended next steps, which I think is actually really important because this is coming from our Department of Health and Aged Care and also the new Centre for Disease Control, where they suggest that a cost-benefit analysis be undertaken to identify the best approach to reducing waste from nitrous leaks. And this could include avoiding the use of nitrous where possible, isolating nitrous flow for areas in a healthcare facility where nitrous is no longer in use. For instance, some have found that when they actually look at where their nitrous infrastructure is, there might be nitrous infrastructure and wall outlets going to areas that are no longer, where it's no longer needed, for instance, the library or a ward. Avoid installing new nitrous piping and decommissioning existing piping where possible, either of the whole facility or potentially isolated zones. Other considerations that healthcare facilities should be looking into is actually working out where the clear roles and responsibilities are for regular testing and reporting. Because I think there's probably many on this webinar tonight and around the country who, when they've actually started investigating, digging to find out what's being done in their healthcare facility about detecting nitrous leaks, have been quite astounded about the sort of the lack of accountability and clear plan for trying to detect and manage these. Ensure that there's regular testing happening at our facilities to detect any new nitrous leaks, because of course they can happen at any time. Allow for alternative leak detection methods to be tried and compared, and to just get a better understanding of nitrous use over time for a facility. Think about how we can look at identifying cases or where unnecessary or low value use of nitrous is occurring, and look further to educate our whole entire healthcare workforce on the appropriate use of nitrous oxide. And finally, but not least, in Australia at least, we need to start thinking about what we actually do with the cylinders, minimising the amount of nitrous oxide that goes back to the manufacturers, because it is currently being vented, and advocating for ways to move forward to try and prevent the venting of nitrous cylinders when they are returned to the suppliers. So I hope this guideline will be of use for many across the country and perhaps even broader, as we all sort of grapple with this really important greenhouse gas impact that really is a low-hanging fruit that we should all be addressing. Thank you. I think I've stopped sharing. Is that right?
I think that's correct. Amazing, Eugenie. Excellent to see that that document is now finally live. Can you take us back to when that document was first conceived? And we'll just kind of compare that to Paul's rapid fire consensus.
Well, you may or may not remember, Kaz, but it was actually, I think, first conceived in February of 2023. So we're talking a long time ago and it actually came out of a desire to try and almost audit the nitrous leaks that were being, we were hearing about that were being found around the country. So increasing anecdotal stories about significant nitrous leaks. As far as I'm aware, in Australia, there are only 2 actual publications of peer-reviewed publications of hospitals that have identified nitrous leaks. That's at the Western Footscray Hospital and Alfred. Otherwise, none of the leak detection data has been published. So we had we were aspiring to try and produce a database to do that, but that sort of quickly, or quite relatively quickly, kind of moved into, well, if we're going to do that, wouldn't it be good to have a standard way of measuring nitrous oxide leaks in Australia? And then deciding, well, actually, there probably isn't one standard way of measuring the leaks, and that maybe we should provide or develop this guideline. Because I really, as I said, feel that in Australia at least, many of us are still trying to convince our healthcare facilities that this is an issue, and we are not able to go straight to decommissioning, even though that's what we might like to do. We need to be somehow, unfortunately, we seem to have to prove to them that it's a problem first still.
Correct. I agree with your sentiments there. Can I get the panel to please turn on their cameras? We've entered the discussion portion of tonight, and we've got quite a number of questions that have come through to the Q&A. I'd like to thank everyone for presenting flawlessly. That's gone really, really well. The first question comes from Justin Skono. So I'm just finding it. Eugenie, I think actually maybe Eugenie and then Wynne might be able to discuss this. Can you cover, this is from Justin Skono, can you cover the efforts made to deal with leaks in hospitals where they were found? What sort of resources were thrown at this? And is there evidence that it is simply impossible to have a low leak medical gas network?
I can try, but I think what sort of resources were thrown at? I know at Footscray, and Forbes is on the line there, that they found it was only one leak point, and that was relatively easy to fix. And the same at the Alfred, they found one major leak point, which was also relatively easy and didn't need that many resources or financial resources to fix. But I am aware of other hospitals that have found leaks and haven't actually fixed their leaks yet, even though they are significant. Sorry, I'm in a room that's gone dark on me. There we go. Is it impossible to have a low leak medical gas network? Possibly for nitrous. I mean, it seems like pretty much, as many would know, almost all of the hospitals, not all, but irrespective of the age of them, when they are actually actively tested for leaks, do have significant leaks. So it may be impossible. I can't say that for sure, but it seems like the evidence is tending towards that way. Someone else might have a better idea than me on that.
Wynne or Paul or Kelly?
Well, in our case, we decided because we were somewhat influenced by Brian Cheesepro's efforts, who did actually spend a very long time in the Portland area trying to chase down leaks around his facility, which was a newer facility than our more than 60-year-old physical plant that spanned multiple floors and across a street as well. We thought our chances of identifying leakage was close to zero, of finding sufficient numbers of leaks. Brian did make a lot of efforts and made some incremental increase in efficiency, but only saved about 10% with all the leaks that they found. And virtually any connection is a potential leak, whether it's, at a gauge, at a turn, there are just limitless numbers of potential places where you could have a deficiency in your system. So I think newer systems probably have a better chance of maybe having only minor flaws of some worn out O-rings at various connector points. And you might get some big gains in a short period of time if you had very sensitive measurement tools that could give you real-time feedback, as we heard about at the ANSCA meeting earlier this year. So I think that there are reasons to consider at least trying if you think there's a reasonable chance.
I think just to add to that, I think it's technically possible to get a better system with fewer leaks, but it's very expensive to retrofit, which is what would have to happen in a lot of places. And I think just because of the nature of the gas itself, it's an oxidant, and over time you might be able to improve it initially, but those problems will perpetually come back theoretically. So certainly from the UK perspective, I think most places, if not every place that is now starting to look at it or is in the process along the journey of looking at it, are not bothering with looking at where the leaks are, because there's an obvious solution at the end that is less expensive. So the kind of the mainstay of the way it's done now is almost, we know they're there somewhere, let's just go to the solution rather than trying to fix it in a different way that we might have to continually keep on trying to fix.
Yeah, I would just add that, like, the bigger the pipeline, the longer the pipeline, the more valves, the more outlets, the more leakage. And there's also, like in our case, leakage that wasn't detected through leak detection, so I think micro leaks are a real problem. What we're doing in one of our new buildings, our new acute services building at another one of our hospitals, is the compromise sort of outcome that we came to was we're going to install a very small reticulated nitrous supply only to birthing suite and have the manifold as close as possible to the birthing suite with the pipeline as short as possible. We're just doing everything we can to prevent providing the situation where leaks can happen. But and then, as I think I mentioned in my presentation, for some other parts of the hospital, where they use it a lot less, they'll just use the portable cylinders. I think part of all of the problem here is the way that hospitals are designed, where the gases are stored, and the pipelines, the way that they run. Like, I've seen some of the line maps for our building designs, and it just blows your mind when you see it's just hard to comprehend how many pipes are running behind all those walls, how far they go from the bottle to the wall outlet. It's when you see that, you sort of think, wow, okay, the way that this is designed really needs to change.
Excellent. The next question is, can the panel comment on why so much nitrous oxide has been leaking into the atmosphere? Is this a problem with nitrous oxide, or are other gases leaking as much? Is there a lack of monitoring, lack of maintenance, or is nitrous more leaky than other gases?
I'll start. Oh, no, Eugenie, you go.
Oh, well, I'm not, I mean, the only other, we've got air and we've got oxygen that's actually through a whole lot of pipes, and nitrous, really. So our anesthetic gases come in cylinders at the point of care. And oxygen may well be leaking as well. We probably haven't decided to look for that. It's not a greenhouse gas. So I guess when we're thinking about it in this perspective, that's not an issue. I guess a financial might be actually a financial problem, because it's probably more expensive than nitrous. So I'm not sure about that. So that might be leaking as well. But I guess as far as addressing greenhouse gas emissions, nitrous is the one. And I noticed that someone said in, I think Forbes in the chat that methane, our other gas leaks as well, our household gas leaks.
Right.
There's been a little bit of work done in the UK, just kind of small scale on oxygen, and it does leak quite a lot from a lot of the vacuum insulated devices, unsurprisingly. It's difficult to say any more than that. At the minute, there hasn't really been any big studies done, certainly not in the UK. We know it leaks. I think the issue with nitrous is inherent to two things, which we've already discussed. One is the nature of the pipelines itself and all the joins and the length of it. And the other is the nature of the gas and the fact that left to its own devices, it will slowly corrode through eventually anyway. And because of the environmental concerns, obviously, it's way, way above the concerns around oxygen at the minute, which would, we think, be purely financial at the moment. Not any less important, but a different frame of looking at it, obviously.
I agree. Thanks, Paul. The next question is, what protocols and methods exist in hospitals to prevent cylinder diversion and theft?
I think it's actually very ad hoc, and you might be able to add more, Kaz, but
I had a discussion with our ED colleagues today who have just transitioned to point of care cylinders in the last month or so, and they've identified that our gas supplier, Core Gas, has a barcode and a number on every cylinder that moves into our facility. And so they track them so that they can send bills to the right department, as well as make sure that they collect as many cylinders as they return. So that seems that kind of there is some ownership from the gas supply companies. I don't have any insight into the processes of what happens if there's a discrepancy. But yeah, it sounds like at least there is some process with us, and that's with Core Gas. I don't know if anyone here has BOC as their supplier, what BOC does, but I imagine they would have a similar process. Wynne, was there any concern in your area when you transitioned to this, or Kelly?
We have not identified that as a concern. We are only storing, because in our particular situation, we have mounted nitrous on each of they're actually affixed to the anesthesia machines. And so we really only have 2 to 4 cylinders sitting freely in a quasi storage location. We haven't really identified a significant risk yet. And there doesn't seem to be an attraction, at least in our corner of the world yet, to abscond with nitrous tanks. I'm sure that period is coming, but we have fentanyl to deal with, which is a much bigger scourge in the Pacific Northwest. And so as a result, we haven't put a lot of effort towards managing that concern.
Paul, is it a concern in the UK?
Yeah, it is, but the general consensus is that the small cylinders at a very base level are less attractive than the big cylinders that form the manifold, so they're less likely, and inherently what a lot of places, there's no one size fits all in the UK or anywhere really for how organisations keep them, but most of the size E cylinders in the places that transitioned in the UK are kept within the theatre suite themselves, so inherently there's security systems before you even get into that area, those areas of the hospital, which for most organisations are enough to it'd be very difficult to get into where they're stored if they're stored in those areas. Whereas the big manifold cylinders generally are outside at a location somewhere else that doesn't necessarily have people around them all the time. So I think the attraction to try and get in and get those is inherently less anyway, right from the offset.
I'd say similar for us. We have, I showed you a few rogue cylinders that were poorly stored in that image, but most of ours are only accessible by the building engineers and some clinical staff, and they are behind locked gates or in secure areas. So yeah, well, I've never heard of any theft. I've seen it in the media from Scotland and the UK, but I haven't heard of it locally for us. But we just want to make sure that if we move towards decommissioning, and that results in us increasing the number of portable cylinders and the way that they're being used around the hospital, then we need to accompany that with a firm protocol on how they are handled and stored and moved. So to have that governance over it.
Nice one. The next question I think we'll move on to is from Matt Jenks in Dunedin. How big a problem is venting to atmosphere of returned cylinders to gas companies? Is there anything that can be done to regulate this practice? Is there a role for anaesthetists to advocate on this?
I can give you the UK perspective on that, if that helps as a start. So I mentioned it briefly in the presentation. Part of the process of us producing the consensus statement was to speak to BOC about what they were doing, because it was fairly well known that the cylinders are going back to, and I didn't want this to come up necessarily as a criticism of BOC. I think that's the way it's always worked, is that the cylinders go back and whatever's left in them gets cracked open to the atmosphere. So one of our concerns when we were doing the statement was that if we're advocating the use of these small cylinders, where the actual amount of nitrous that we're using might be less, but the number of cylinders will probably increase because of the differences in size, at least at the beginning, we don't really want to perpetuate the problem with that being cracked open to air. Now, what BOC have done in the UK or
Sorry,
in the
Paul,
process of doing.
just to clarify, when you say cracked open to air, you don't mean put through a nitrous oxide destruction or cracking unit. You just mean vented.
Just being cracked open. Yeah.
Yep.
Vented out to the atmosphere. Unchanged effectively. So what BOC are involved with at the minute in the UK is registering the process with the MHRA in the UK, which is the Medicines and Healthcare Products Regulatory Agency, because they do have the technology effectively to refill cylinders without cracking them open first, so that they can refill partly filled cylinders. But there's not a precedent for that anywhere else in the world yet, so it's going to take quite a long time to get that through in the UK. What we were very keen on, which we're still pushing them on, and that, as they've agreed to in principle, is a statement that when that technology becomes available, it will be used for all of the returned cylinders. So we're in a less than perfect solution at the minute, which is that those ones that are going to send back, that is the only option at the minute, realistically. We did discuss with them the notion of whether it can be put through the actual catalytic crackers. So instead of being just open to air, whether what's returned can go through the catalytic crackers. And the rough estimate that we got was that were they to do that, the price of a size E cylinder would go from £3 to £700, which is obviously not viable either way. So they're pursuing this other way of doing it. And hopefully as soon as they've got that done, that will be their primary way of dealing with it. And then that will be that problem hopefully put to bed. But there's not an easy solution for that we can click our fingers and do, because it's obviously dependent on the suppliers to do that.
And I don't know, Paul, you might be able to comment, but I've also seen a clip from the UK. So, I mean, obviously it's beholden on us to try and minimise how much residual nitrous goes back in the cylinders to the suppliers. Because at the moment, it's my understanding that in Australia, it is actually open to air as well. And I believe there are places in the UK who are actually weighing their nitrous cylinders to give them a more accurate estimate of how much might be left and when it's appropriate to replace the cylinder. So a bit more accuracy there. One of our problems, I believe, is because it is a medicine, and like other medicines, the suppliers can't just fill it up if there's still some residual, at the moment, residual nitrous in the cylinders, so they are required to empty them before they refill them. And I definitely think that's something that anaesthetists, the healthcare community, as we are addressing our leaks, we also need to be then looking at how we can manage and some of the greenhouse gas emissions that are therefore then happening at the point of the supplier as well.
I would agree, and I think we have quite a lot of soft power as a specialty when it comes to this, because we are realistically the only specialty that uses pure nitrous oxide. So we can't dictate what suppliers do or what companies do, but I think we have quite a big role in advocating for what they can do. And certainly in the UK, BOC have been pretty receptive to the discussions that we've had with them and are listening, which is good.
Awesome. Well, hopefully if the UK segment of BOC can create a system, hopefully that can be implemented in other nations to help tackle this problem. I think the next series of questions will focus more on the practicalities of portable cylinder management, particularly with regards to anaesthetics. This question's from Chris Mitchell. In the hospitals that have decommissioned in the UK, have they all changed to having portable nitrous cylinders that are connected to the anaesthetic as required by the blue low pressure hoses? And what problems have been experienced?
I guess that's one for me. Well, in general, most places that I've spoken to have either gone to the portable cylinders or they've just got rid of nitrous oxide completely. Obviously, that's an individual organisation choice rather than you can't have a blanket approach to that. The issues that we've encountered in various different places from going to the portable cylinders have tended to be around machine checks. So whether if somebody wants to connect a cylinder in between cases, sometimes the machine hasn't liked that and it's had to go through a full check again. And obviously there's the perpetual issue of what happens if the cylinder runs out, mid-induction or mid-procedure if you're using nitrous. There isn't an easy answer to that because it's difficult to switch cylinders out mid-procedure. So the kind of broad answer to that is just switch to air for the remainder of that procedure and up your volatile effectively. It's not exactly a completely satisfactory answer, but it's the best one that we've got. But in general, I don't know of any organisation, certainly in the UK, obviously I haven't spoken to every single one, but I don't know of anyone that's attempted to attack the pipeline issue directly and keep the manifold. It has been either get rid of the manifold or start the process of getting rid of the manifold and move to the portable cylinders, or just get rid of the manifold and don't use nitrous at all, effectively.
And I should just make the comment that one of the hospitals that I work in is quite keen to go down the decommissioning line, but at the moment, not all the anaesthetic machines can actually have portable nitrous cylinders attached to them. So that is potentially a barrier for some of our hospitals, and also something to think about as you're moving forward and buying anaesthetic machines or involved in the purchasing of anaesthetic machines.
Eugenie, do you think we need to go down the route of having nitrous oxide yolks on the back of our anaesthetic machines, or do you think we need to accept the somewhat cumbersome option of having a cylinder in theatre?
Oh, you mean a separate cylinder? So not, I guess, I think having a cylinder in theatre is actually fine. Is that what you meant by that?
Yeah, I think the video that I've seen from Cliff Shelton in the UK pushed a cylinder on
a separate one. Yeah.
A cylinder on a trolley into theatre and then connected via the nitrous oxide hose. Wynne, was that the model that your hospital moved to, or did you have nitrous yolks on the back of your machines?
We were fortunate that our machines were already set up with yolks, and we actually already had nitrous mounted on all the machines. So for us, as a redundancy, so we had really, really limited effort to make the move to that mode. I was answering in the chat though, it does waste a little bit of nitrous on a daily basis because of the machine check of having the nitrous there, but we only have one tech for every maybe 4 to 6 theaters. And so carrying out a midday addition of adding a portable nitrous and then redoing the machine check would probably break our tech team. And so for us, it was more feasible to go with the yolks on the machines.
Okay, and so that sounds like it would have been a relatively seamless transition for you if your original setup was wall outlet as well as a nitrous yoke.
We did it at 12:30 on a Tuesday in the middle of an operative day.
Nice. Excellent. We'll move to the next question. Well, actually, I think you've just kind of answered that one. How do you balance the concern for theatres running for cylinders running empty compared to returning partially full cylinders? Did you do this on a weight base, or when were you changing your cylinders, and what were the triggers?
Well, here in Dunedin, I would say that Matthew Jenks has put together quite a nice little worksheet that I know he has shared out to some individuals, where our tanks are being measured each time that they're being brought to theater. And there is a replacement threshold once the tank reaches a given weight that they're going to be replaced. That is not our methodology, since ours are actually mounted to our machines in Seattle, and so we rely on seeing that pressure change. I have to admit I never learned bar for the nitrous. It's 40 something, I think, but in PSI it's 745 PSI, which is the American measurement for the nitrous pressure on the portable tank. And so we know that we still have a quarter of a tank remaining when it drops below that set pressure. And so at that point, you can sort of begin the discussion of how much do I think I'm going to need going forward clinically as to whether or not a tank change is necessary before you start that case.
Okay, so you would run the cylinders until they started to depressurize and then look at swapping them out?
Yes.
Cool. The next question is for Kelly. Can you shed some light on the process of shifting away from the reticulated nitrous and setting up point of care cylinders? And did you leave the pipe work of the nitrous oxide reticulated system in place?
Yes, we did leave the pipeline in place because that would have caused a lot more disruption to go about removing it all. And it's fairly, it's not causing any problem just having the little pipes there in the background, not connected to anything. So, yeah, we did leave them there. What was the other first part of the question? Sorry, Kaz?
Can you elaborate on the process of shifting away from reticulated nitrous?
Oh, yeah. So as I mentioned, with the Prince Charles, it was fairly easy because the anaesthetic department had proactively of their own accord made that strong commitment to reducing as much as possible their nitrous use. And because they didn't have maternity, they felt that they could manage without the reticulation. It's the reason why we're taking more of a bespoke approach to our other facilities, because it's not, there's maternity where that seems to be where the most reluctance is to move to portable cylinders, even though there is the advantage that a birthing mother can, if she has a long labour, can move around with the cylinder, go outside, take it in the bathroom. There are some benefits like that. But then, of course, there's also OHS risks that you have to consider with that as well. So, yeah, we're really looking at it on a case-by-case basis. And I suppose the way that I was able to get this so easily over the line with the executives and the clinical governance exec director and facility directors was because we weren't saying we want to take away all your nitrous. We were saying where it's still clinically required or preferred, you're still able to use it with the portable cylinders. And sort of when you make the whole case around emissions reduction, environmental governance, our climate change targets that we need to meet, as well as all the lost cost of paying for gas that is more than half is likely to be leaking and not making it to patients. I feel as though the argument was sound, and we just need to work with the stakeholders, nurses and doctors and anaesthetists at each facility, look at the layout of that facility, look at the clinical caseload and how best to support them to set up an applicable process that's going to work for everyone at that site. And even I'm in the process now of collecting all of that information, and we don't even have the same contracts, the same suppliers, the same service protocols, the same refill schedule in some of our hospitals. It's the BTS team that oversee the cylinders and the refill. In other hospitals, it's overseen by the building engineers, but it's the wardies that order the refill. Like, it's not even that's not consistent. So that's why I say a bespoke approach, because I need to really do that due diligence, go and speak to all the stakeholders at each facility and make sure I map out exactly what's happening and where we can make the improvements, and do that case by case. So I can't really give here's a tip, how to make the portable cylinder transition work smoothly. I think you just have to put that work in to finding the best way for each facility. Yeah.
Fantastic. Well, it's 7:26. I'm going to follow up with one question that I'll repeat to each panelist. And then I think we'll call it good night. I've really enjoyed the discussion. I'm going to start in speaker order. But what is the first step to nitrous oxide reduction that attendees can do tomorrow? Paul?
I think in the vast majority of cases, without being overly controversial, in the vast majority of cases, we probably don't need to use it anyway, to be honest. So we can individually just reduce our practice with fairly minimal impact. There's a growing consensus in the UK amongst paediatric anaesthetists to just not use it for gas inductions anymore. And I think that's something that takes time to do, but that is the easiest way. Before we start thinking about any technical solutions to the nitrous problem, we can just reduce our usage off our own backs if we want to, and then that drives any further change that we want to do. So that would be the first, most straightforward thing I'd say.
Wing, what is the first step to nitrous oxide reduction that attendees can do tomorrow?
I think find some colleagues that haven't thought about it and see if they're where they are in their understanding about this. I think there's a small but very motivated group of individuals who have thought quite a lot about this, and I still find pockets of individuals who appear to be completely unaware of any of this potential issue. And so I guess spreading the word, increasing the conversations around the topic, and then using that as momentum to create change.
Okay. Kelly, what is the first step to nitrous oxide reduction that attendees can do tomorrow?
Okay, well, I'll try to give a different answer just to, create some more and varied information. I think if you're an anaesthetist, go and find your sustainability lead, or if you're a sustainability lead, go and find a passionate anaesthetist, pair up and start to, I think you need to, that saying, you can't monitor what you don't measure, or you can't change what you don't measure. I think you need to develop a position. I don't think it's a quick, easy step. I think you really need to, but I do think sustainability and clinical need to join forces and make a case and start to champion that case in your organisation. And then as you go down that rabbit hole of finding the information that you need to find, you'll start to work out who are the other stakeholders. And I think definitely talking about the pervasiveness of nitrous oxide as a greenhouse gas, what it does to global warming, what it does to ozone. I think that, yeah, you've just got to build your case. And I think that, I think I said this in the beginning, I don't think sustainability officers can drive this alone, and I don't think anaesthetists can drive it alone. I think it is different with the other anaesthetic gases, where you have a clinical choice to substitute one gas for another or one medicine for another in other cases. But with this one, because there isn't really another equivalent gas to change, to swap over to for the way that nitrous is used clinically, I think that, yeah, joining forces, building a case, get your facts straight of what's going on in your facility, and start to do the showcasing of that, drive it, get it known, and build the momentum, build the support for it. Yeah.
Fantastic. Eugenie, what is the first step to nitrous oxide reduction that attendees can do tomorrow?
Well, I've gone from really what Kelly and the others said, but probably Kelly said, so I think it's probably best we need to start investigating what's happening in our hospital. And it's not just within the anaesthetic department when it comes to the nitrous infrastructure and the purchasing. So engaging the engineers, the facility managers, it might be pharmacy, actually trying to find out how much is purchased and who's in control of that, and what the maintenance schedule might be when it comes to looking at leaks, and then developing a team with those people. If I'm presuming it's not already happening, to see how the next best steps when it comes to actually working out how much is purchased and where you might need to go to determine your leak amounts.
Fantastic. Well, that sums up a excellent session. I've certainly learned a lot, and I thank all of the speakers for their time. We'll end the session soon, and I'll get the speakers to just hang online for a couple of minutes to just round things out. I'd really like to thank all of the participants tonight for all of their questions. If there are any follow-up questions, I'm sure any of the panel are open to receiving emails. I'd also like to mention that there's an active group within the ANZCA ESN and across Australia and New Zealand that if anyone is interested in being involved with, we can point you in the right direction. I'd also like to give a little plug to any interested anaesthetists to join ANZCA's Environmental Sustainability Network. We don't bombard you with too many emails, but it's useful to stay in touch. So thank you everyone for your participation tonight. There ends the webinar.